Good morning, everybody. Thanks for joining us to celebrate NHS Fab Change Day for Morecambe Bay. My name's Adam Lucas. I'm the i3's digital analyst. I'm just going to be helping to link all the presenters in this morning for the live event. So for those of you that haven't been on a Microsoft Live event before, it's slightly different to Teams, so it doesn't work exactly the same. So you might see a little question and answers bubble on your screens. So if you do have any questions for any of the presenters today, feel free to pop a question in there, and then we'll review those questions and then post the answers when we can. So I'm going to start off with a video from the chief. So sit back and watch the videos. Thank you.
Good morning, folks. My name's Aaron Cummins. I'm the Chief Exec here at the University Hospitals of Morecambe Bay, and welcome to Fab NHS Change Day 2020. We've got a great relationship with the Fab Change Day. We've been doing it for a number of years now. I'm always really excited at this time of year that we get the opportunity to share what we've been up to, some of the innovations, some of the work that we've been doing together. But equally, I'm really happy to see what everyone else in the country has done, because we nick quite a bit and we do pinch with pride here in Morecambe Bay. So today is quite a different Fab Change Day. Just the fact that I'm not there today opening events, and we're doing this on camera, sort of remotely. This is about the learning that we've taken through COVID-19 and the pandemic. And today we've split into two halves. This morning we're going to be talking about, how we've maintained Morecambe Bay being a great place to work through a really difficult period, particularly the work we've done with occupational health, our Flourish programme, the health and wellbeing approach, keeping each other, supported through some really difficult times, some great work in that area. And then this afternoon we're going to be talking about the work we've done to make sure Morecambe Bay is still a great place to be cared for, even though we've had some real difficulties over the last 6-7 months. So you hear lots from our teams around, care pathway changes or innovations in our clinics, or some digital innovations we've put in place. So really excited to hear what we've all been up to over the last sort of 6-7 months, sharing some of that through the Fab Change Day hashtag and on social media, and I'm looking forward to hearing more from you over the course of today, which will absolutely be gegging in and having a look. So enjoy the day, welcome, and we'll make sure that we get the most out of it that we can. Thank you.
Okay, great. So we're going to start off this morning's presentations with the i3 batch. So we'll be hearing from Mark Hadwin, myself, Kelly Hayes, and Tracy Kelly.
Hello, my name is Mark Hadwin. I'm the Head of Digital Services in the i3 department, and in this presentation I'm going to show you how we automated our COVID antibody and swab testing service. Okay, so the challenge we were set was to create a system or a service that would reduce our admin bottleneck, a system that was safe, it was simple to use, it was sustainable, it was also scalable. So I think everybody was expecting the volumes of patients that we were going to have to swab test, particularly going through the system, to increase. And we didn't want to create a service that would then exponentially or increase our reliance on admin staff. So the challenges were fairly clear from the start. Okay, so this is the right slide. We follow the USA approach, which is to understand, simplify and automate the process. And actually, when we think about this process, it's fairly simple. A patient wants to see a clinician, so they can do that together and have a result going back to the patient. And there are a few other considerations, such as to-do lists and patient clinic lists, and also lists for the clinician of patients, particularly those that have tested positive or need further follow-up. Okay, so what we tried to do was use our existing technologies to create some building blocks based on our simplified process. So sitting behind everything was a small database where all of the requests and processing happens. At the very front edge of the system, or the user-facing end, is an NDL FXE form, which we created ourselves, and I'll show you in a moment. At the heart of the system is a Blue Prism robot, and then providing access to the information and the data in there are some operational reports and audits as well. I think one of the things that made our response to automating the COVID screening antibody services was being nimble. And I think also using the word need carefully on this slide has tried to differentiate between a system or a service requirement and a need. There is no handbook for developing this sort of service. So really, as needs arise, we responded to them, and that be whether patients who were unable to make it into the hospital to have a test and needed testing at home, or patients who were having their surgery at the hospital but actually lived outside of the area. So all of these types of different requirements popped up as we built our service. So I think being dynamic and flexible and being able to do what's needed to be done helped make this a success. Right, so because I'm a bit of a chicken, I've decided to incorporate a video of our e-form being completed rather than doing a live demo. Here we see a test patient being entered into the system, and some of the things that we've taken as a benefit, if you like, from using an e-form is the ability to validate the data as it's being entered. So here we can see a mobile phone number going in, which is validated against patterns of mobile phone numbers. So we get a pretty good set of data as it goes in. And then towards the end of the form, we ask some additional questions about whether the patient is symptomatic or asymptomatic, and as in this case, which organisation do they work for? Well, it's UHMB staff members, so we ask some additional questions. And then towards the end of the form, we're asking about whether the staff member is patient-facing or not. So moving on to the next screen, we have the option to take part in the Canine study, which is a research project. And then on to the final part of the form, where you actually book your date and your time of your appointment. You can also select home if you're unable to make it into the hospital. But in this case, we'll pick a date and a time at the Royal Lancaster Infirmary and just book that appointment. So after booking the appointment, we get a confirmation that the request has been successfully submitted. And then following that, we will send either a text or an email back to the patient confirming that as well. Okay, here we'll see the robot keying in the data that was entered in the e-form into our TQuest requesting system. It does it pretty quickly, as you can see. The system takes around about 45 seconds to a minute to perform a single entry. Here it will select the COVID-19 screen, which is on the microbiology group. The pop-up comes up and the system will then choose the organisation that we selected for the patient, which is in this case is UHMB staff. Click save, and then when it finally saves the record again, that will send it off to the lab. So following analysis in the lab, the result is then available. It is then texted or emailed back to the patient, and you can see on the right hand side of the screen now, at the very top is a confirmation of an appointment via email, which includes, for example, a map of the hospital. The mobile phone is a text result of a COVID swab, and at the bottom, a slightly more detailed result of a positive swab test, which includes links to the government advice, which has allowed us to keep abreast of the fairly rapidly changing advice which we can issue out. This information is then provided to the hub as a list, particularly for positive patients, so that they can then ring those patients up and discuss their result with them. Okay, just to display on one screen some of the stats and numbers for the system. It's performing over 200 tests per day through the automated service now, which is, and virtually zero admin for those tests. The only real admin that's required is printing the labels out in the clinic and putting those on the bottles. We think that saves us over 50 hours per day across our sites, and with reduced input into computer systems and not having to telephone patients with negative results. 95% of all our results are with the patient within 24 hours, and 100% of those results which are positive are with the patient within 24 hours. And on to the final slide, and really what I'd like to do is pick up a couple of points of our next stages of the development of this service. First is what we're calling closing the loop, and what we mean by this is allowing patients to confirm that they've read and understood the text or email that we've sent to them. And the second point is care home access. We're looking to reduce the time it takes to get results back to care homes and giving them direct access into the system for results of their residents. We think will help us achieve that goal. Thank you for listening. If you have any questions about robots or robotic process automation, please feel free to get in touch with us.
Hi, I'm Kelly Hayes. I'm the Analytics and Data Science Manager, and I'm going to be talking about the outpatient clinical review tool that we've developed and are using at UHMB. So earlier on in the year, when the first wave of COVID hit, the decision was taken to scale back outpatient clinics in an attempt to help contain the virus and to reduce the risk of infection. Unfortunately, this meant that our waiting list sizes increased, and when we first started this project, we had more than 116,000 patients waiting for an appointment. So it was clear to us as an organisation that we needed an intelligent and proactive approach to the problem, and that we needed to be able to clinically review each patient to be able to prioritise their care and make sure that the most urgent cases were seen. And we also needed to assess if there was a different way of managing some patients that might be more appropriate for them, such as moving them to nurse-led clinics or moving their appointments to telephone or video consultations. So our solution to this problem was to develop the outpatient clinical review tool, which I'll show you now. So this is a list of all waiting list entries, which are appointments that patients are waiting for, and clinicians can use this to review either those that are assigned to them as a care provider or those that are related to their specialty. It can be filtered in various different ways, including by treatment function or care provider or priority. And it's fully secured so that only clinicians can access and review it. The tool pulls in relevant information such as patient names, age, appointment type, etc. from Lorenzo, which is our electronic patient record, and the fields that are displayed in the tool can be fully configured to the user's preference. The clinicians then use the information provided here, as well as consulting the patient record, to clinically review and make a decision about what's the most appropriate course of action for the patient. So for example, they might decide that this is a new appointment that needs an urgent telephone consult, or this is a follow-up appointment that could be moved to a patient-initiated follow-up, and that can all be recorded here through the tool. They might also decide that this is just a routine appointment, and as such it can be deferred for a few weeks so that a more urgent patient can be seen first, and they can record the deferral through here as well. This information is then passed automatically to our patient contact centre that books the appointments, so the tool also allows clinicians to input booking instructions so that it can aid the booking team. When they finish reviewing, they can submit and save the data using the buttons here, and then the patient contact centre have their own sister tool to this that pulls through the information that the clinicians have input and allows them to make the necessary changes in the electronic patient record so that it's reflected there as well. And to give you an idea of how it's being used, through the tool, clinicians have reviewed 76,951 waiting list entries, and we're now down to 26,498 that need reviewing, and that includes newly added ones. So we're down quite significantly from the initial 116,000. 34,396 appointments have been moved from face-to-face to telephone or video appointments. And for 9,412, the patients have been discharged as they don't require any more care, or they've been put onto patient-initiated follow-up plans, which enables patients to get in touch if they require further care. So I think we can say that it's been widely used and it's been instrumental in our planning and approach to COVID recovery.
Hey everyone, my name is Adam Lucas. I'm a digital analyst for the i3 Digital Services Department, and I'm just going to talk to you about Attend Anywhere, which is our video consultation platform. So what is Attend Anywhere? As a response to COVID, NHS England provided us with a platform to run video consultations. Now this allows patients to access online waiting rooms via tablet, smartphone, laptops, home PCs. It also enabled multiple healthcare providers or carers, parents to be involved in appointments at the same time as well. If you do want to look at some information for yourself, you can go to the website displayed on the screen there. So that's uhmb.nhs.uk/video call, and there's some videos and some information on Attend Anywhere itself as well. So an important part of these appointments is how the patients access these online waiting rooms. So to begin with, what we did for some of the services that were early adopters, it was we embedded an SMS text message sender within Lorenzo. So that when bookings were made, we could send the patient a text message that would give them a link that they could click on from their device that would take them straight to the online waiting rooms. Now, as we move into the rest of the services, it's much grander scale, and we'll be doing this by using appointment letters, which we've embedded QR codes so people can scan the letter with the device. We'll also then be moving into the future release of e-letters, which will let us send electronic versions of letters, PDF documents that again contain these links for patients to get there. We've also made a UHMB website which will direct patients as a sort of a digital front door, so they can test equipment, make sure that video consultation is right for them, and find out more information before then entering those waiting rooms. So let's take a quick look at what Attend Anywhere actually looks like from the clinician's perspective.
The care provider will go to the Attend Anywhere website and log in with their email and password. This will take them directly to their appropriate waiting area. They click on the patient's name, they can notify and send a message, or click Join Call. Once joined on, the patient and care provider should be able to see each other. The toolbar from the bottom of the screen will allow the care provider to use the text function. The patient can also text back. You can mute your microphone or switch your camera off if needed. You can also use the share screen functionality. This will enable you to share Lorenzo, PACS, or any web browser you've got open. Click Stop Sharing to return to the camera view. You can also add extra guests into the meeting, whether that's an extra care provider, a parent, or a carer. You can send either an email or a text message, or copy the link details to send to them. If there's any problems with the connection, use the refresh button just to reset the call. Once the consultation is finished, click on the end button. You can return to the call, place the patient back in the waiting area if needed, or finish the call for everyone. Once the consultation is ended, the patient will be presented with the Attend Anywhere feedback form.
So using that feedback form that you just saw at the end of the demo there, we've collected information from patients to gather how they've actually found those video consultations, with them being a big change from actual face-to-face appointments. And it's been resoundingly positive from a wide age range of patients, from young families enjoying not having to travel and take time off work to find car parking spaces and spend however long it takes to get to the hospital in the first place, or two parents being able to join appointments from completely different locations to both be there for the appointment as well. Also, some elderly patients have really enjoyed this. We thought that might be a bit of a fact that turned a lot of patients away from this, but we found that even some patients, in this case, some patients in their 80s here, that found it very easy, instructions were clear, and they managed it no problem. It's obviously not the case for everybody, but we're finding more and more people these days have got a tablet or a smartphone or someone in their household that has a laptop or equipment that can be used. So it's been resoundingly good feedback. We've had patients attending virtual consultations from using from the workplaces of work, from home. We've had some that have been sat in an airport waiting to go on holiday from their own car before they set off. So it's again can be helpful for cutting down on things like DNA rates and missed appointments. So video appointments are given as a great alternative to just telephone appointments in this time where we need to see as many patients as we can, but also keep patient visitations to the hospital side down. So moving forward, I think we'll see video consultations more and more, but obviously not taking away the need for those important face-to-face clinics as well. So if you'd like to find out more about Attend Anywhere, like I say, feel free to jump onto the UHMB website. That's uhmb.nhs.uk/video call. Thanks very much.
Hello, my name is Tracy Carling and I am the Implementation Manager at Morecambe Bay. I'd like to talk to you about the e-observation deployment which ran between the 14th of April until the 29th of May 2020 this year during the pandemic. Firstly, e-observations, what are they? Observations create a new score which needs to have 6 physiological measurements. For example, the blood pressure, the temperature, the respiratory rate to actually create a score. This score indicates the condition and well-being of the patient in line with the national guidance. Before this deployment, observations were all recorded on paper charts. Now, e-observations are recorded on iPads, iPhones, laptops on wheels, computers and whiteboards if required. The initial scope of the deployment was to pilot the NEWS 2, Scales 1 and 2, the BP and positioning charts and strikeout functionality with a visible audit trail to award at the RLI and at Furness General Hospital. We performed a limited pilot on AFU when COVID hit and our plans had to be deferred to fully deploy to the ward. About a month into the pandemic, a lot of the staff who had fallen ill began returning to work, and whilst the wards had very poorly patients, the patient to clinician ratio was unprecedented. We discussed the option of carrying out a pilot on Ward 6, who had actually been in the original pilot scope, and the ward manager and matron weighed up the risks and felt that a limited pilot would be possible. After only a few days, it became apparent that the ward were managing well with the equipment and the app itself, and the matron asked if we could roll out to Ward 9 and Ward 7 respectively, which we did over the next 15 days. After a period of reflection and feedback from the wards, there was an understanding that the pilot wards had needed limited support once they were up and running. There was an opportunity to roll out e-observations at a greater scale, and there was an approach to the Nursing Design Authority and the senior nursing teams for their clinical opinion. There was an incredible amount of support from all the clinical teams who worked quickly to ensure that this was signed off by clinical directors and head nurses alike. SOPs were written and plans were developed which entailed completing the rollout of e-observations from ED to the back door of each hospital. On the slide below you can see a ward pegboard. There is a red box around the EWS score and there's a further red box around a set of clocks. The EWS score indicates the status of the patient. As you can see, the patients on the pegboards with a score of 1 to 4 are in green, those with a score of 6 are in amber, and those with a score of 9 and 10 are in red. The patient names reflect the current score of the observation to give clinicians a quick synopsis view of all the patients on the ward. The clocks also have coloured status. Green are completed, amber are 3/4 of the way through the clinical parameter, red are outside of the recommended parameter, and an asterisk indicates that the patient is no longer on observation. The patient flow ward pegboard takes its context from the EPR with admissions, discharges and transfers updating in real time. After an e-observation is added to the system, it refreshes immediately. Or if there is no activity, it automatically refreshes every 8 minutes. The Patient Flow app is an incredibly useful tool. It allows users to update the whiteboards from laptops, iPads, desktops, and can be accessed simultaneously whilst operating the EPR. Patient Flow is customisable to suit different departments such as ED, outpatients, endoscopy, and inpatient wards. It also provides an extremely robust business continuity model in the event of any system disturbance. We started the deployment with a NEWS 2, the BPM position and observation strikeout functionality. And within a few weeks, we also had the ventilation, the BiPAP and CPAP, neurological obs, and retrospective observations. Over the next 6 weeks, we'll be working with the maternity teams to pilot on Ward 17 and the labour ward at the Royal Lancaster Infirmary. There are many benefits to recording e-observations. The calculation, auto plotting and visual picture of the observation chart is the most obvious benefit of recording digitally. The score also links to an escalation, advice and guidance, which has to be acknowledged in real time. Clinicians are able to view the information on all existing clinical equipment and have the advantage of being able to view the information off-site using secure trust equipment. During COVID, this has been invaluable for clinicians who are shielding, working from home or wanting frequent updates on patients when off the ward. The most recent addition of the ventilation observation allows the users to track patients on oxygen and ventilators. The respiratory nurse practitioners commented how invaluable it had been for them to be able to access information and give timely advice to the wards. The slide below plots the timeline and the number of users who were trained using TMS or face-to-face coaching. I think the success factors speak for themselves, but I would like to say a massive thanks to the wards, the departments, the managers, the teams, the matrons, the senior nursing teams, the HPs, the doctors, the resource teams and the I3 teams who all went the extra mile. This was an absolute multidisciplinary approach project, and I don't think it would have happened without the full commitment of everybody involved. Thank you.
Lancaster City Council's Community Hub is here to give help about anything from getting food and medication to housing and benefits advice. We can also connect you to a local volunteer. It's okay to ask.
It's okay just to ask someone to listen. Together we can talk through your worries.
It's okay to ask for help if you need somebody to pick up your prescription. It's okay to ask for help if you need somebody to do some shopping for you. It's okay to ask for help if you need somebody to speak to on the phone.
Hi, my name's Sue. I'm a social prescriber for the Carnforth and Milnthorpe Primary Care Network. It's okay to ask me for help. I can help arrange food bank parcels to be delivered for you and your family. Together we can help and support each other.
It's okay to ask if you need help and support with a cancer diagnosis or a bereavement in your family. Cancer Care are here for you.
COVID-19 support group. We say it's okay to ask.
Okay, thanks to everybody for those first round of presentations. Up next, we've got some of the workforce department, starting with Jeanette Thorpe. So I'll hand over to you, Jeanette.
Okay, thank you very much. I shall just. Okay, so welcome everyone. For those who haven't met me before, I'm Jeanette Thorpe from the Learning and Development team. I'm here along with my colleague Ross Hayes. And we're going to be the first of two presentations from the Workforce and Organisational Development Directorate. So for those of you, just to outline, the Workforce and Organisational Development team is comprised of 9 departments. Learning and Organisational Development is one of them. And just to outline what we did over the COVID period, we all changed our working practices. We went to 7-day working. We had staff who were working remotely and staff who were working on site, so we always had a presence to be able to support staff. We set up daily briefings across all those teams so we could support each other, and we also worked across those teams so we didn't just stick to our ordinary roles. For the focus of today's Fab Change Day, we're going to have a look at some work that the Learning and Development and Organisational Development team did during COVID, along with our occupational health colleagues, and Claire will actually be following me. So as far as the Learning and Organisational Development team, we've got 10 people in the team, some of which you may have met, some of which you've probably spoken to on the phone or had emails from. The areas of our work include apprenticeships, core skills framework, managing the training management system, also known as TMS. We're looking at leadership and management development. We support new colleagues coming into the organisation via corporate induction. We're also involved in appraisal, a range of different workshops, including assertion and various support across different teams as well. So, focusing on what we actually did during COVID, yes, we continued some of our own work, so that was around supporting colleagues who were on apprenticeship programmes, supporting colleagues with their core skills training, any problems with the training management systems. But we also worked alongside a range of other people to support different activities. This actually took us beyond what we would normally do. So we had a big learning curve in relation to understanding the different aspects of work, and also in relation to understanding some of the technology. We worked alongside the mask fitting teams, the clinical skills teams to set up training for staff being redeployed, along with our practice educators. We worked alongside the health and safety team and other practice specialist experts in relation to looking at how we can present some of the information and the training differently. Ourselves as a team, as I say, we've also spent time working with others, and my colleague Ross spent time working with the occupational health team, and he's going to just outline what his experience was.
Thanks, Jeanette. Yeah, so obviously it was a bit stressful at first, adapting to a new situation, a new method of working. Obviously my talents don't lie in occupational health, they lie in helping people with the TMS system. And certainly in the early days, when the guidance seemed to change almost daily as to what we're looking for in terms of the COVID symptoms, a lot of mental adjustment was required to keep up with that information. And at first it did feel a bit isolating. Obviously I didn't know the people that I was working with as well as I might have done. And I was away from my team quite a lot as well. So that was obviously a little bit of a transition. And I have to admit at first it did, like I say, feel a bit isolating. But Claire and the team were fantastic in looking after us. They made sure that they helped us through difficult times. They gave us the information that we needed when we needed it. Made sure that we took breaks and things like that when we needed them as well. And it was just a good experience to actually meet people from across the trust. Also, I think certainly before COVID, we had an issue where departments would work sort of separately from each other, and that was kind of went away during the initial phase of the pandemic. It was great to meet people from not just the occupational health team, but also those that were also helping out as well. And it helps feel more like one trust rather than different departments. We're working towards a common goal, which is not always obvious when we're working separately from each other. And it was just a very uplifting experience knowing that we're making a difference as well. I mean, even if it was just providing information to someone who was a bit worried about what those symptoms had, or just worried in general about the COVID situation. And obviously by helping to arrange those tests, we made sure people were either able to get back into work, or if they obviously were positive, then make sure that they weren't spreading it further. So even though there were times where it did get a bit overwhelming, just because there were so many calls coming through, obviously just trying to keep up with that. I have to admit, it did get to a point where I was getting a bit nervous every time the phone rang. But at the end of the day, you knew that you're making a difference and doing your part during a very difficult time. And that was just a very motivational experience.
Thank you, Ross. So just, even though we've obviously covered all of those areas during COVID, we just want to focus on two aspects to give you some more information. And one of them is around the support that we gave to staff across all different wards and departments. So what part of our work meant that we came into contact with lots of different people, including those people joining the trust for the very first time, people, existing members of staff who were being redeployed across different areas. We also had just connecting with people who were having to work differently, were working from home, and along with those staff who were coming in to be mask fitted. What we were able to do was actually provide that confidential, safe space for people to talk about their experiences and feelings. Lots of people were anxious, they were upset and very emotional about what was happening to them, what they could see happening to other people. There were concerns about their families and friends. So we actually provided that listening ear for people to be able to just to step back, reflect, and just spend some time thinking about how they are feeling at the moment. This helped us actually make some connections across the different departments. For some staff, they had some really unfortunate situations happened, so we were able to help them unpick some of those issues and then join the dots as well across the organisation if those situations were happening right the way across. We can connect with other people and in relation to the different workforce cells, the different departments, so we could try and resolve some of those issues. One of our team, Sally, along with a number of other colleagues, set up a pilot session around time to talk, and that was where 2 members of staff had to be redeployed into completely different roles to what they were used to, and they actually talked us through their experiences. What they found was when they were narrating their experiences, they were very emotional. They didn't think that was going to be the case, but actually that's what happened. And it was very emotional and uplifting to hear their experiences, but also enabled us to gather a lot more information. So all the conversations which we had were confidential, but we were picking up key themes in relation to issues or how people felt, and that could then contribute towards organisational learning. And we've been able to feed that into different groups so we can prepare for the future. One of our other areas of learning and the work that we've been doing is supporting the development of others.
Yes, so we've done some extensive redevelopment of the ways we support the Trust. One of the biggest changes this year has been to the appraisal system, which we've worked closely with the Digital Solutions team to set up the COVID check-in tab. This allows users to share with the manager how the pandemic affected them personally. It gives an opportunity to vent their frustrations, if any, and talk about what has worked for them, what hasn't, which ensures that everyone gets the chance to relate those experiences while they're still fresh in their mind. And obviously, some of that information will be used going forward to try and help the overall experience as the pandemic continues. We've also developed virtual learning sessions to replace our traditional face-to-face workshops, basically using Microsoft Teams to deliver them virtually rather than face-to-face. This has involved a lot of work within the team to try and find a system that worked for everyone. There was a bit of a steep learning curve at first, and obviously our facilitators have years of experience doing things face-to-face, so adapting to that new system was a bit new, obviously. But I think as a team we worked together to try and make sure that everyone got a chance to do what was most comfortable for them. So those who are better at facilitating got to facilitate, and those who are better at the IT side of things got to do the technical. So essentially how we work these things, certainly for our COVID appraisal information sessions, which are 30-minute sessions going into the changes to this year's appraisal and how the COVID check-in tab works. These are facilitated by someone who will talk directly to the learners, and also an admin person in the room to deal with the technical issues, things like making sure that the presentation's working, Teams is working, people get the chance to ask questions, and so on. There's also our appraisal for appraisers information sessions as well, which we've adapted to the virtual learning environment. Again, this was traditionally a face-to-face workshop, but now it was done by Teams. And again, just adapting it to working in virtual environment rather than sitting down in workshop doing face-to-face sessions. It's again maybe a bit shorter, a bit more technically focused, and a bit of a chance for people to not sit all day for the computer, essentially. We've also done some extensive work on our leadership fundamentals programs. These were being worked on pre-COVID, and obviously due to the pandemic have had to be changed even further. But it's been a good opportunity though to find out what works, what doesn't, and kind of cut the fat a bit in those regards. One of the things we've done, for example, is due to the pandemic, set up a leading teams remotely sessions, which go into how managers can keep in touch with their teams, even if they are on different sites, in different places, working from home. Encourage them to keep that managerial duties going, and also to make sure that people are kept looked after and not getting too stressed out, too feel like they're isolated, feel like they're not part of the team, even if they are working from home. We have also worked with Eden Charles on a conducive passionate leadership workshop, which again has been done virtually rather than face-to-face, and just gives those a chance to continue their leadership development even with the pandemic going on. And thankfully, this has led to a lot of positive feedback from us. I won't read out every example, but as you can see, there's certainly a lot of nice things being said about us. And again, it's not just it's feedback that's been given after sessions, it's feedback on social media, it's feedback from colleagues. So just again, it's very encouraging to see that even during this difficult time, we're still able to continue the training, still continue that quality of standard that we want to maintain. And it's just wonderful that so many people have been understanding while we've been adjusting during this difficult time.
So just to bring it all together then, even though this has been a difficult time for lots of people, as long for us, we've on reflection, we've identified a number of positive outcomes for the learning and organisational development team. Absolutely recognise that this has been a shared experience by everybody, shared living through COVID, shared having to adapt to doing things differently, and we've provided lots of support to everybody within the team and wider. Everybody's felt valued when we reflected on it as a team. There's been some tasks that we've done and we've involved in everybody, which was completely different to how we might have done it previously. Our knowledge has been increased because of the connections that we've had with other people and other departments. We've got a greater knowledge of understanding of what their roles are within their departments. We feel that we've contributed to organisational learning through all the information that we've gathered from our different conversations, which is really important to feed into our training, but also to feed into improve the colleague experience. So overall, as a learning and organisational development team, we feel really proud of our contribution during COVID and proud of our achievements, both personally and organisationally. Thank you very much.
Brilliant. Thanks very much, Jeanette and Ross. So I'm going to hand over to Claire and Gemma from the Occupational Health Department now.
Thank you, Adam. Good morning. My name's Claire Hill. I'm the Occupational Health and Wellbeing Lead for the Trust.
My name is Gemma Mason. I'm a Nurse Manager in Occupational Health.
And we are here this morning really to give you a little whistle-stop tour of the work that the Occupational Health and Wellbeing Department carried out and supported our colleagues across the Trust and continue to. We are a small team working across the Bay and we are here to support both the physical and psychological needs of our workforce. So once the pandemic did hit the UK, within 24 hours, we became responsible really for all of the COVID-related colleague support with the ongoing and ever-changing government guidance, specifically around all health conditions, a shielding that came on board and all of our pregnant colleagues, as well as the need for triaging and swabbing any of our symptomatic staff, which we'll go on to a bit later on. Our change of service really was to support what the need was at the time, and as some of you within the Trust will be aware, that's been ever changing as we've continued to move forward, as well as maintaining our business as usual. We chose to step down none of our normal services and to continue our business as usual, and in fact we strengthened the offer of what we were able to give at the time by becoming a 7-day service. The needs of our colleagues turned quickly really to planning an extended and varied psychological support package, ranging from daily ward department and welfare visits to ensuring that we had bespoke psychological packages available to meet the needs of all of our staff. We wanted to ensure that our routes to meet the people ranged from face-to-face to fully electronic, to options that are available outside of our geographic patch as well, understanding that our colleagues don't just sit here maybe at Lancaster or at Kendal. We currently are obviously seeing ourselves within phase 2, which Gemma's going to go into in a little bit more detail in a second. And by arranging all of these psychological phases, it allowed us to be able to clearly see what was needed now and what would be needed as we moved through the 3 phases, which then gave us a better plan really to ensure that the support we were giving was the right support. This was ever changing, and I'm pleased really that we were proactive enough to be able to act and develop the needs of our colleagues timely as we were going through this challenge.
Okay, so as Claire's just shown, we've had the 3 phases that we planned. Phase 1 was relatively short compared to the current and ongoing phase 2, but it gave us time to start building on our support network and services. During phase 1, we started to change our approach to meet the needs of our staff by adapting our services to both in-person, over the phone and video call services, as well as online resources and trust communications. It was in phase 1 where we developed our first colleague support pack, which contained all the detail for available in-house and local services, plus coping strategies and techniques to help manage things such as anxiety, stress and sleep issues. And at this point, we also reconfigured all the therapist diaries, the nurse diaries, so that we're able to offer same-day appointments for staff to access hypnotherapy, CBT and counselling and health advisor appointments. We also started to visit areas and departments to meet with staff to offer our services in person and help resolve any queries there and then. Next slide. Super. Oh, we've gone, there we go. Moving on to phase 2 happened quite quickly, and apart from a slight reprieve during the summer, we remain in this phase. This phase is about responding to the needs of the staff as quickly as possible. In phase 2, we've continued to offer all that we've introduced in phase 1, but with a closer focus on responding to trauma, loss, and dynamic ways of reaching staff. In phase 2, all of our therapies became telephone, video call or face-to-face. We also recognise that all of our staff will continue to require physiotherapy access to remain physically well, and so our physiotherapy services can continue through phase 1 and 2. From the introduction of phase 2, our TRIM team services have been used 21 times from March to date for COVID-related events. So TRIM stands for Trauma Risk Management, and it's a strategy and a service offered to our staff which helps to look at acute stress factors in staff and look for signs of PTSD. And by becoming aware of these early, we've also been able to then offer therapies for trauma, such as EMDR therapy and trauma-focused CBT. And we feel that this early intervention has enabled staff to stay well and in work. Phase 2 also saw the launch of our second colleague support pack, which has been delivered by hand and electronically. Occupational health trust communications includes a daily contact reminding staff of services, coping strategies and help available. And we've also recently linked in with a COVID rehabilitation team, which occupational health team can refer staff into as well. Phase 2 has also seen an increase in the occupational health teams working closer with managers and whole departments to support them, to support departments as a team. So, for example, currently we're running sessions for teams on trauma, PTSD and recognising wellness. For some teams, we've run these as wholes to 1-2 hour sessions, but other teams we've run these on site for 30-minute mini sessions for smaller numbers of the teams so that they can be released from the ward work and every staff member gets an opportunity to attend. And it's this flexible and ever-changing approach that we've found that's been needed during COVID, which is in line with the ever-changing landscape within the Trust due to COVID.
Sorry, Gemma, it's not responding.
Okay, well, I'll just carry on. So phase 3 is our recovery phase, which we're not in yet. And what we plan to do here is increase our TRIM team numbers and expand our therapy services to offer a more bespoke, more dynamic team, adding to increase a range of skill sets and options for staff. So we'll also be launching our brand new Wellness Check programme, which will be offered to every staff member, and that's next year. And that will be providing them with a range of health checks, feedback and personal goal setting, and again offering referrals to a range of services. And we'll be continuing to build on the education for staff, again on PTSD, trauma loss, bereavement, and an understanding of what we've been through and moving on.
So just to talk about our current situation, so we are currently receiving around 350 calls per day. The team have become an integral part of the swabbing service, triaging and referring all symptomatic colleagues and household members. We also have extended this service to our colleagues within the community, such as Lancashire Constabulary, North West Ambulance Services, local hospices, and many more key workers. We are now also supporting the daily management of potential and confirmed outbreak situations, ensuring really that the safety of our patients and colleagues remains at the forefront of everything that we are doing as a department. As a trust, colleague physical and psychological support has become one of the top 4 priorities for 2020-21. And our plan now is to make sure that we are looking at the actual health needs of our colleagues. So the introduction of the wellness check programme that Gemma discussed will give us some actual data around what do our colleagues need, what is the current status of their health, and how can we support and improve that, in the hope that as we move forward over the next 12 to 18 months, we can become a much more proactive service, meeting the actual needs, as opposed to some wellbeing programme that maybe only might touch 10% of our actual workforce. And this will then come in line with the relaunch really and review of our Flourish strategy once we've been able to obtain the data from the wellness check programmes. And that's us.
Thank you.
Thank you.
Brilliant. So thanks to everybody from the workforce department there. So up next, I'm just going to share with you a video from the estates team, and then we're going to hand over to Stephen Ramsbottom and his colleagues to go through some more of the work estates and capital services have been doing during COVID. Okay, great stuff. So, Stephen, over to you.
Can you hear us?
That's better.
Yeah, excellent. We've prepared a short video, but I'm just going to hand over to my colleague Mark just to say a few words first of all.
Hi there. Hopefully everybody can hear me. Can you hear me, Adam? Good stuff. Hi, my name's Mark Campton, and I manage and work alongside a dedicated small team of individuals, and that's to achieve our capital plan. We work with staff and patient groups on capital projects ranging from a few £1,000s up to multi-million. We've put this together, this short video showing what we've achieved over the past few years, our response to COVID, and what the future holds for us in capital. Enjoy, and any questions at the end. Thanks very much for watching. Any questions? Happy to take them. As you can see, we're working hard just to do catch up on a lot of projects and make the place a better place for our staff and our patients. Thank you.
Thanks very much, guys. All right, so up next we have got Jackie from the catering department. Are you there, Jackie?
Hi, morning.
Morning, Jackie. Away you go. I'll just put your presentation on for you.
Okay, thank you. Hi, just going to speak a bit this morning about what catering services have been doing at the Royal Lancaster Infirmary, Westmoreland General Hospital and Furness General Hospitals over the COVID period. It's been quite an interesting time, as I'll explain as we go along. Despite shortages of some supplies that we've had, food-wise, equipment-wise, it's been quite a challenging time, but we've managed to keep our services going. We've had reduced staffing numbers due to quite a few people shielding, etc. Obviously, the odd positive test and sickness absence as normal. We have still provided a full meal service for patients and staff with minimal disruption throughout the pandemic as we possibly can. The Trust and Chief Exec decided that they would offer staff 50% discount on food in the restaurants during the COVID period, and this is still in place at the moment. Meals for patient and the creche that we've served across the Trust during the COVID today are over 200,000, as you can see, and bed numbers are rising at the moment, so that will increase over the next few weeks. Restaurants have remained open for staff only, but we have served a full menu, so the staff have been able to come in, get hot meals, snacks, etc. all the time during this COVID period. Service have always been maintained in Cumbria for Millham Hospital and the Meals on Wheels service that we provide out in the community. And all services have been maintained in-house, including sandwich production and modified textures, which we do at 2 different sites to accommodate all 3 Trust sites. For safety in our restaurants, we started in March with all our staff in catering across all 3 sites wearing PPE at all times. We put screens at the payment points to keep our staff safe and customers safe. Cutlery is individually wrapped and handed out at all till points. The restaurants and to-go coffee bars have become cashless, and that's gone down quite well, better than what we thought it would do, really. Tables are socially distanced in the restaurant, and we are only allowed 2 people to sit at each table, and if somebody moves tables or joins in a group, we do ask them to remove and adhere to social distancing. Tables and chairs are sanitised between customers. When a customer pays at the till, they get a sign which they put on the table when they're finished, and that lets the catering staff know that we will then sanitise that table before somebody else comes to sit there, and then it's clean for the next customers. We've got social distancing when queuing. We've got stickers on the floor at 2 metres distances. We've hand sanitizer available at all entrances and till points for customers to use whenever they need to. And anybody coming in the restaurant must be wearing a mask even when coming into the restaurant and queuing, and only remove it when they're sat at a table eating. We've decided that all the restaurants at all 3 sites and to go to coffee bars will be staff only, so we're not serving visitors or any patients that may come down into the restaurants. Track and trace system in place, so whoever comes in the restaurant, they do sign and put a contact number so we can contact them if anybody comes back and says that somebody's tested positive. During the COVID situation, our Alive restaurant was currently started refurbishment just after Christmas. And of course, we got halfway, taking the old survey out, etc. And due to lockdown, it all came to a standstill. So quite quickly, we got a full temporary survey area in place that we thought would only be there for a few weeks, which turned out to be quite a few months. But that did keep everybody fed and a full service, so staff had something at whatever time of day they needed something to eat to be able to come down and get something. The new Ashton restaurant was finally reopened in 2020 and is now a bright, welcoming place for all staff to come and have their meal breaks. It's gone down quite well. We've now got a new baguette and snack areas, which staff seem to quite like. Catering's had to think a bit outside the box during COVID. Things kept appearing at the beginning from different suppliers. I mean, we had 20,000 Easter eggs delivered and drinks and packs and things for staff that were donated by suppliers, and not necessarily supplier specific that we use, but from national suppliers. Didn't know they were coming, just turned up, wagons, 10,000 Easter eggs. Can you sort these out, distribute them? So we did. Catering distributed them across all 3 sites. We even managed to get community services out in the community to have their share. So that was quite an experience for us as well. We set aside a part of the restaurant at the Skylight at the Ashton restaurant at Royal Lancaster Infirmary as a designated wobble room from staff up on the wards or anywhere they dealt with patients that might be feeling a bit sort of upset or anything, where they could come, have a quiet 10-15 minutes, and we converted our lounge area of the restaurant into that for staff to be able to use sort of between 7 a.m. and sort of 7 p.m. at night, and then out of hours there were other areas in the hospital that staff could use. Meals for patients, we took the decision to serve from the trolley outside the ward entrance, so catering staff that may have 3 wards to serve weren't going from ward to ward and having to enter the wards, even though they do wash their hands and change PPE between each wards. But we thought it was an extra precaution for infection control that our staff weren't taking trolleys or themselves into a possible COVID positive area. Catering have also been working with patient experience. As you know, a lot of hospitals took the decisions for no relatives or friends to be able to visit patients. So patient experience have been emailing management teams at all 3 sites with messages and photographs that have been sent in by loved ones for patients, which we've printed off twice a day, put in envelopes, and then we send out with a meal trolley so that when they get the meals, they're actually getting, if somebody sent a message in, a message photograph from somebody that they love or friends, so that keeps them in touch with the outside world. During lockdown and the COVID period, we've also, as a catering department, tried to still keep our projects going. We're still on with our electronic meal ordering system, trying to improve that and hoping to get sort of nutritional values onto the system, etc. So but that's what we've been working on during the time. So even though we've had additional pressures during COVID, we've still kept positive and looked at further improving our services. If anybody wants any more information, I've provided 3 of the phone numbers for all 3 sites. If anybody wants to give us a ring, please do so to ask any questions. Thank you.
Fantastic, thanks for that update, Jackie. So just going to play you another video from the ICC next, and then we're going to hand over to Georgina Lim.
We're from the Ulverston Food Waste Project.
It's okay to come and collect some free food from our drop-in sessions. You'll be helping us to reduce surplus food from going to landfill.
Hi, I'm Simone from SLDC's Customer Services team. We know times are tough. If you're struggling to pay your council tax or need advice about housing benefit claims, then please talk to us. Ignoring the problem will only make things worse. Remember, it's okay to ask for help.
Hi, it's okay to ask for help. If you've recently lost your job,
or you're struggling to find work and you need some support with a CV or some basic skills to help you become employable, we can help.
Hello, my name's Cara Stride and I am Development Lead for Kendal Integrated Care Community. I'm just here today to say that there are lots of services out there that can support you. To find out more about what's available in the local area, visit cumbria.gov.uk. These are really difficult times. It's okay to ask for help.
Hi, I'm Susie. If you're homeless now or are worried that you might become homeless and need help and advice, then please contact us at South Lakeland District Council. It's okay to ask for help and we're here to help you.
At South Lakes Centre Advice, we provide free confidential advice on a whole range of issues. So if you're falling into debt, struggling with your finances, or if you've got an employment issue, concerned about redundancy, or just need that help to make a benefit claim, don't forget it's okay to ask.
Cumbria's tourism industry is one of the great successes of the county, but 2020 has been a very different year for all of us. It's had huge impacts on our operators, on our staff and on our visitors. Many people have been struggling through this crisis and we say it's okay to ask. It's okay to ask the many organisations who can help all of us through this. Cumbria's tourism industry will be great again, but it will need help from a lot of people to make this happen.
Hello, here at the Windermere District Food Bank, along with the Satellite and Ambleside, we just want you to know that whatever your circumstances, it's okay to ask.
Hello, I'm Glenys Marriott from the Cumbria Victims Charitable Trust. We help victims who are in need, distress, hardship or sickness as a result of crime and who are vulnerable and who need help to cope or recover or to avoid re-victimisation or to replace essential items, and those who have limited resources and there's no other funding available for them.
Okay, great. So over to you, Georgina.
Okay, thanks, Adam. Hi, I'm Georgina Livingston. I'm one of the ICC development leads for two of the integrated care communities in South Lakes, which are Grangeon Lakes and Mid-Furness ICCs. In normal times, I've got a team in Grangeon Lakes of 8 staff who would be going out into the community, supporting people by visiting them in their own homes, assessing their health and well-being, and preparing care plans and signposting and referring them to other services. During the early part of the pandemic, when staff colleagues couldn't go out to visit people, staff volunteered to help other services who were struggling. And I'd just like to show you a video which outlines some of their experiences and some of the learning during that time.
During COVID-19, I was redeployed to the Rapid Response Team in Mid-Furness. This gave me the opportunity to work with a multidisciplinary team that supports crisis care continually and not just during the pandemic. The team's run by Shauna Lee, who are very welcoming and very supportive. I gained valuable experience working alongside specialist OTs, and they provided me with a sense of normality during this trying time. Although the aim was to avoid hospital admission, this sadly was not always the case, and I feel privileged to have been part of a team that provided the necessary care when it was needed most.
Hi, my name is Lynn Cassidy.
I work as a case manager at Grange and Lakes ICC. This is just a short video to inform you of my redeployment at the start of the COVID pandemic. I was actually redeployed to assist with the recovery hubs. These were beds that were set up, some were in Barrow Academy, some were in Kendal Leisure Centre, and there was also a set up in Lancaster. So obviously to assist with these beds and potential if patients were filling these beds, we needed staff to assist in helping their patients recover. So my initial job was to shortlist the potential staff that would be needed to help with these recovery beds. So with working from home, I could do this working quietly. There was quite a lot of potential staff that had applied for these roles, and obviously they needed shortlisting for interview. This I set about both for Barrow, Kendal and for Lancaster, and then I assisted with interviewing for both Barrow and Kendal. This meant that I was working alongside acute matrons that worked in the acute sector, and obviously the community managers as well. This was quite a steep learning curve for myself, shortlisting potential staff, and it was quite a task really. Fortunately the beds weren't needed and the recovery hubs were stepped down, thankfully.
Hi, I'm Nina. I'm one of the care coordinators for the Grange and Lakes ICC and an occupational therapist by background. In May I was redeployed for 2 months to the South Lakes Community Respiratory Team to support with the launch of the COVID Rehab Pathway 1. So we were visiting people who had been discharged from hospital having had moderate to severe complications of COVID. So that is, they'd been needing oxygen therapy on the wards or they'd required ventilating on intensive care. It was a difficult time. It's always hard joining a new team and also working with an unfamiliar disease. Little was known about COVID at the time, so it was a really steep learning curve for us all. It was a positive experience for me in that I was enabled to work as an occupational therapist, so using my core skills and also working alongside other therapists. On returning to the ICC, I feel I've learnt a lot about the effects of COVID, both on individuals and on their families, and it allowed really good opportunity to network with different individuals and different community teams, which enhances my role as a care coordinator.
So up next, we've got Janet Manning from the acute care team. Are you there, Janet?
I'm here, yeah. Good morning, everybody. I'll just share my screen. So my name's Janet Manning. I'm the patient safety matron. My title has changed quite recently, so and I manage the resus and acute care team across the trust. Oh, not at the beginning. Okay, so I've been asked today to talk to you about the resus and acute care and our response to COVID-19, what we did to support training and education during this time. So our problem was that we needed to maintain training and compliance and safety of the patients, even though that we're in the grips of a worldwide pandemic. So this has required us to do quite a lot of adaptations during this time. Initially, we were asked we needed to provide support to staff on the wards and coming for training. We still needed to maintain the training that we were able to do, which was nominally BLS, and we started doing some donning and doffing training to support staff for this skill. It was new and it was an important requirement. We need to maintain our BLS compliance. It's one of the core core skills, and it's required for clinical people in the trust to maintain. And we also were there to help reduce the anxiety and instill confidence in colleagues. There were lots of colleagues that we met that were going to be redeployed, that hadn't worked on wards for quite a number of years, had different skill sets. So that we did a lot of talking and listening and helping them reduce their anxiety. But we have had some challenges along the way. Prior to COVID, we delivered lots of different courses, and we had some sites to do that. At Lancaster, it was RLI CTAC. At Costa, the clinical training room up in Furness General, and we used the macular unit at Westmoreland General. So we've got a lovely picture there of Dr. Barry, Dr. Brodison and Mr. Hurlicker learning their BLS at one of our sessions on CTAC. So they're just some of the courses that we would normally be part of, including on that would be the annual training day and other simulation events that happen on a frequent basis. So since February, we've had 8 different venues to train in. This has caused some issues, as you can imagine. We've had to be really adaptive to the changing circumstances, and we've been all around, particularly Medical Unit 1 at the RLI. So some of those pictures there, we've got the old theatre on Ward 6. We've got Macular Unit. Obviously, that was taken prior to COVID with no social distancing. We've got Costa up at Furness General. We've got Ward 2 and we've got NTEC. So as you can see, we have been around. So this has required the team to do an awful lot of moving. We're getting really good at packing our equipment up, putting it into cages and getting it moved somewhere else. So although it's been quite stressful at times, we have made lots of new friends out and about around the trust and worked closely with Jamie's team. Initially as well, the team were quite depleted due to redeployment and sickness absence. We were sent initially to Ripley School, where they kindly lent us the sixth form centre, and we shared that space with clinical skills. And in the early stages, as I said before, we responded to staff that were facing redeployment. We provided lots of donning and doffing training, as well as supporting BLS for new staff down at NTEC, attending cardiac arrests on the wards and maintaining equipment throughout the trust, part of our normal daily activity. So BLS is the thing that we've had to change the most, because this was the course that we maintained throughout COVID. So we had to identify new ways to deliver BLS training. Prior to COVID, we would normally have an hour sessions with 18 staff members at once. That people would come on audit days and pay days. They would drop in and we would train numerous people that day. So obviously, because that we had new venues, we had new guidelines and social distancing to consider. We had to take down quite a lot of sessions, reduce them in number, so we're repeating them more frequently. But we still needed to ensure that we had the key elements of training included, that we maintain the standardised BLS algorithm, that there's still a practical component, and we included the COVID-19 guidance. So what we've done now is that all these sessions are now bookable on TMS, and they're half-hourly sessions, and we make sure that we do the important parts to make sure that the staff are safe and that the patients remain safe as well. We need to communicate regularly about venue changes. Staff have unfortunately turned up at the wrong place because we've moved at the last minute. But we have had quite a lot of success over the time. In the period of between March and October this year, we've delivered 964 staff training sessions for BLS. We've maintained the PBLS sessions across all sites for 202 staff. We've done bespoke fluid balance training and ad hoc training for 161 staff. And we've also done the AKI sepsis and fluid balance training in the ATD for 265 staff. So despite all the difficulties that we've still had staff engagement, and we've still managed to provide good numbers for training. Since August, and including another venue changed, we've reinstated more vital training. So whilst we were maintaining social distancing and ensuring PPE, we had to make sure that candidates remained in bubbles, and we've managed to reinstate the EILS course. We've done the EALS course, paediatric life support, and ILS research for 16. So we've not, the numbers aren't as high as normally they would be, but we have maintained courses. Currently, we're still able to offer the EALS course, the EALS course, and PLS and anaesthetic training days. So these are all now being held at the Queen Victoria Centre on Ward 6, which can cause a bit of a problem for some staff, being that it's off-site, but these are the courses that are at least half a day, if not a full day. So it makes it easier for staff to get away if they're released for training. Obviously, they're all socially distanced, and we do need to wear PPE at all times. All those courses, again, bookable on TMS. With regards to BLS and PBLS, we're still providing that at the RLI, FGH and Westmoreland General. The venues are flexible. We're currently sat on Ward 2, but I believe that we will be moving off here sometime this afternoon. Not sure where to yet, but it's important that staff check where the training is going to be. Each course is for a maximum of 6, and we wear PPE throughout. The course currently consists of a video and then a practical assessment of CPR. We also talk about the COVID-specific requirements of BLS. And once trained, all your compliance will be recorded on TMS as usual. If you've got any questions regarding acute care or resuscitation, please do get in contact there. All our email addresses there. We can support the wards with ad hoc training if needed. We can look at escalation aspects of acute care. We don't necessarily need to stick to formal courses such as BLS or ALS. So please do get in contact if you think there's anything that we can support you with. But thank you very much for listening.
Thanks, Janet.
Hi, I'd just like to say that the Build a Better Bay programme, if you've got any questions or any queries, if you want to either contact Suzanne Hargreaves, who's the programme director, Helen Pye, Liz McDougall, or myself, will be happy to give you further information about the work that the programme's taking forward.
Just to say about the It's OK videos, each of our ICC development teams, development areas have been running the It's OK to Ask campaign, where there's been over 25 different charities and volunteer organisations that have come together to provide that support for communities. And it's just amazing. So it's still running, it's still there. Things are still open for us to ask as well. So please make use of these facilities. On that note, I'd like to bring this morning's Fab Change to an end. I know we're a little bit early, but we don't want to rerun things because you've already been able to watch those already. So I'd like to say a massive thank you to our morning presenters, and of course to Adam for being our technical whiz co-producer, top producer in the background that's helped out keep us all together and keep our presenters together. And again, thank you for tuning in, and we will see you back again at 2 o'clock this afternoon. Thank you very much.